All right, welcome everybody. So what we're going to be presenting on is culturally sensitive treatment recommendations for substance use. Oh, my bad. For substance use in Muslims using a medical disease model. So we briefly kind of talked about that, previously. So we'll kind of skip through that just a little bit, but just to kind of keep in mind that throughout this presentation, we just wanted to keep kind of this sentence just in mind when kind of focusing on how we're kind of presenting everything. And so kind of looking at culture as multifaceted in that it's not just a kind of a very general construct. There's a lot of complexity that kind of goes into it. And so kind of understanding that, it includes a lot of factors like the values, the beliefs, the norms we have, just the different ways we think about things, the interactions we have with others, and just kind of understanding how these are very dynamic and that there's a lot of interplay between them. And so kind of how these work on different levels of the individual where it might be an internal level, but then also kind of how that plays in a role in family systems, how they work in their community, and kind of looking at culture more of that broad aspect. And so kind of with that, keeping it with that, just that sentence of how it applies with substance use culture, but also as it applies with Muslim culture, and kind of how those might get integrated with the two in conjunction together. Oh, yeah. So just to kind of go over some kind of prevalence rates. So according to SAMHSA, as of 2014 reports, just over about 50% of Americans in the population ages 12 and older report drinking alcohol at some point in their life, and 17 million of those actually meet criteria for an alcohol use disorder. About 25% of Americans have used tobacco products, ages 12 and older, and then around about 22.2 million Americans have used cannabis, with about 4.2 of those meeting criteria for a cannabis use disorder. And then there's a range when it comes to stimulant use disorder of about 476,000 to 913 Americans actually meeting criteria for that. And that's just dependent on the type of stimulant that they're using, since there is a broad range of different stimulants that qualify as an actual stimulant use disorder. And then around about 246,000 Americans actually meet criteria for hallucinogen use disorder. And this is based on kind of usage patterns, which essentially all of these are based on usage patterns and kind of how they're actually using the substance, and kind of just the methods and as well. And then about between 586,000 and 2 million Americans actually met criteria for an opioid use disorder. And this is also dependent on the type of opioid use that determines kind of the amount of Americans that actually meet criteria for that.
So I'm not going to spend much time on this because Dr. Arkin here is actually her data that we're using, so no pressure for us. But just a brief introduction to kind of how this affects substance use in the Muslim populations. So there is very limited empirical research, part of it being to the culture of shame, guilt, people not wanting to admit their usage. But this data shows that about 6 to 10 million Muslims kind of in America in general, and then about 46.6% of those in the colleges use alcohol the past year. But one of the protective factors, as we've learned, is this having this religious ties to each other, so that it is shown to be lower. We just don't know what it is more in the general population. So that's something to keep in mind, is that we still need to work on getting this data so we can use it effectively in treatment, in coming up with prevention programs. But that kind of is the first step.
And so kind of with kind of moving forward, so there's two models that you'll often see when you're kind of going to substance use programs, that there's more of a focus now on the medical disease model, but in the past there was a lot of push towards this more of a choice-based model. And the reason we kind of brought this up is that kind of the model that a program can take, or that an individual can kind of work from, can really have an impact on how the person sees themselves in relation to having a substance use disorder, especially within certain populations, when you kind of keep it as this choice-based model and saying that it's solely from one's choice, and that it's their just kind of engagement in their behaviors that kind of leads to them engaging in using substances, can really have a negative impact on just kind of how they view themselves and just kind of how they work within the context of their actual system and environment. So that's why now there's more of this push towards the medical disease model, and kind of looking at it more of the biopsychosocial model, and that there is predispositions, there is genetic components that really get put into the play of how we see addiction, how it kind of forms, and how it really kind of is maintained within an individual. as well as kind of seeing like those psychological factors and the social factors of how they all three kind of interplay and work in conjunction together to understand the complexity of substance use as it relates to each individual in and of themselves.
So we're gonna we've gotten a lot of information about, the empirical data, what, the statistics say. So what we want to switch our focus is kind of how do we apply this information? What are the things that we need to take into consideration when working with people who are having substance abuse, not only in the Muslim community, any minority community. So a lot of this can be applied in a culturally sensitive way to many minority populations. But some of the barriers we see that, we have to take into consideration is like, a lot of people in collectivist cultures will only seek treatment after it becomes severe. So you're going to see more of the extreme ends when it's becoming a problem where they can no longer hide it. It's becoming more of an issue within the community and affecting the community at large. Collectivist cultures are not very, individual focused. So if it's just something that's bothering them, it's something distressing, they're not going to likely to seek services until it becomes the bigger problem. Secondly, kind of the beliefs surrounding it. Traditionally, substance use, anything that causes distress, is kind of seen more religiously in terms of, azar or demon possession of some sort. So they might go see a religious leader like an imam or someone to get that support before coming to see someone in the mental health field. There's also this misalignment between Western therapy and Muslim values. Kind of the belief in Western therapy is to work on this self, this individualistic kind of culture where, you're aiming to make yourself better. That might not be the concern for people in a Muslim culture. They're looking to how to integrate themselves back into their community. How do they find meaning in what's going on and in their lives? How do they not affect those around them, such as family members, or meet the pressures of those? And we need to be mindful of that that's what we might be trained as in the Western world is not what they're looking for in their treatment. There's also a mismatch of communication styles. A lot of Muslim cultures have this more nuanced communication style where it's the nonverbals that are important to pay attention to, not the content of what is being spoken. So keeping in mind, what is the client saying, but also what are they not saying to you? What are they showing you in more indirect ways? And so that can be hard for people who are not trained in kind of that nuanced communication style. There's also, like we mentioned, minimal information on minority groups in general of what the prevalence rates are, what kind of are effective-based treatment models that work, what are recommendations, what are the resources available. And lastly, just the lack of knowledge, like we said. Even as clinicians, we don't often know what's available in the community. Who do we turn to if we need information? Let alone who do these clients turn to that we are supposed to be helping? So these are kind of barriers that kind of interfere with treatment-seeking behaviors. So as I mentioned, basically Frank and I did meta-analytic research on just what are some of the suggestions out there that we can do to help make it better for these clients, help them, encourage them to find treatment, because substance use is such a prevalent concern. It has a lot of long-term negative consequences, aside from more the short-term acute problems that can occur. So we want to be mindful of intersectionality and understanding, like we mentioned, that using Western evidence-based practices may not work with a lot of people in minority cultures, especially in the Muslim. So you want to identify what components of the symptomology is related to Western beliefs and what is related to more religious, traditional beliefs, because addressing those from those perspectives has been found to be more effective than kind of just taking this one lens aim and kind of doing it through that view. You also want to incorporate traditional aspects of healing. If that's something that's going to help with adherence, help get them the treatment they need, why not do it? So in terms, one of the common things I do is like we all believe in meditation. That's kind of the new DBT, kind of second, third wave CBT models. That does come from a Muslim culture. We do Bungi, we do this mindfulness. Help incorporate that, bring that back in, because that is a religious thing that we can then reframe for them to help in the treatment, and it has shown to be effective. Then there's the understanding of the purpose of behavior. Why did the person choose to do this method? Why, did they choose stimulants versus opioids? Why alcohol? Understanding those little nuances and stuff. Why they do what they do is really helpful in helping guide the treatment, because then you can address not only the symptoms but the underlying problem itself, which is more long-term focused. It also just allows the client to feel understood, helping them realize that this is not a struggle they have to face alone, that there is support out there. It helps validate their feelings and their distress. You also want to help clients understand their own social cultural identity. A lot of the people who say they struggle with substance abuse, they feel a disconnect from the religious community. So helping them find their way back in or helping them figure out who they are could really help in lowering their distress and helping them, battle some of this stuff they're going through that are causing them to use. You also want to allocate more time to psychoeducation in a lot of minority cultures because they don't have the information, or the information they receive is incorrect, it's inaccurate. So you want to be sure to allocate that time more than maybe you would with other clients or people that you're helping to give them the information that is accurate, that is reliable, guide them to places where they can find that information so that you are working with someone who is knowledgeable rather than having these misbeliefs and kind of guiding them in how they develop themselves within the process of change. You also want to take a more process-oriented approach. This has been shown to kind of be beneficial in minority groups. A lot of them aren't very focused on the cognitive aspect. Like I said, it's very collectivist. It's how is it affecting others. And it's shown that the more that clients are able to find that information for themselves and come to those realizations, the more significant it is for them in the process, and it's more likely to stick with them long term and motivate them to make the changes necessary. It's also, you want to find clinicians who are more strength-based. So someone, I'm not sure how many are familiar with the Adlerian psychotherapy, kind of positive psychology, humanistic approaches. Those incorporate culture as more of this generalized idea rather than a specific thing that you have to insert intentionally. They look at this biopsychosocial model. It's very holistic. It's less shaming and less guilt-inducing for them to be provided with the support and motivation, encouragement, that they are struggling, but there is hope at the end of the tunnel. They can get through this, and that there are resources, and they're not alone in this. You also want to participate in collaborative care approach. Understanding, work with community members to help educate others. Know where you can find resources as the professional, but also help educate yourselves. Maybe there's stuff you don't know. Find that information, be very active, but also help those within the community, help the imams in the Muslim community understand what it is they need to know. I'm not sure if how many of you attended the session yesterday, but this is something kind of we talked about, helping them understand the language to be used and helping them understand what are the identifiers that they need to be watching out for to be able to help the community and then guide them to you through a trusting relationship, and by association you are then trusted. You also want to identify cultural values that are important to the client. We don't want to assume, and the best way to do this is speak to the client. Ask them, what is important to you? What part of your culture, your identity means something to you? It's not the same for everybody, and so how you approach treatment, how you approach providing services is going to vary idiosyncratically for each person. So it's important to do that, to change your kind of framework for doing this based on what is important to the person. Because if you're working on something that's irrelevant to them, they're not likely to return because they'll feel misunderstood. And just being able to be open and understanding allows the stigma to be reduced, that it's okay to talk about this stuff. And I think that is one of the biggest things we found, is just being even able to talk about it and not being judged is very significant factor in continued treatment. And lastly, just because you don't necessarily agree with how a client views things or what their beliefs are, doesn't mean you can't accept them or their beliefs. Just being open-minded that where your framework is, kind of putting that aside and putting yourself in the shoes of the client, because you're there to provide a service for them. So like I said, don't have to accept it or don't have to agree with it, just accept it and understand and use that and integrate it into treatment. And the last one, Frank is just going to talk about that one.
And then also kind of to kind of add on to like with cultural values, like some approaches, like when you think of 12-step programs, they kind of have a certain framework, and sometimes the framework actually might be kind of stigmatizing to the client in relation to how they view themselves. So kind of being aware of, maybe you might have to kind of shift the way that you incorporate the 12-step program or a specific, treatment approach to kind of work within the context of the individual, because it's going to be important that the word usage you use, like the language, kind of has that approach that really takes into account of how they identify as an individual, but also how they identify within that family system, as well as kind of within their overall community. And kind of when you think about like adopting and normalizing language framework and adjusting the word usage, to kind of, instead of making a distinction between like it's us and them, or it's me and it's you, and kind of it's ours and theirs, kind of working in that framework where it's like, if you're working with them, just say kind of like, we struggle with this, and so kind of allowing yourself to kind of get into the, the shoes of that individual, so that way they kind of have that normalizing nature of that, oh, like they really, resonate with me, and they really understand kind of where I'm working from and kind of how this has really affected me and been incorporated into my life. As well as kind of those terms of like addict, alcoholic, junkie, sometimes those can also be very stigmatizing, can have a lot of negative impacts on the individual, because that can also lead to feelings of guilt, feelings of shame. So kind of, getting away from those words and kind of looking at more of like, this is a struggle that you live with, and so let's kind of work within the confines of how do we work through that struggle, which kind of takes it away from that choice base and kind of looks at it more in that it's an illness, it's not just something that's based on choice, especially when you go to like, thinking about abuse and kind of shifting that word from abuse, because abuse implies that you put in that choice to kind of really go into that and kind of changing that framework to like, now it's just substance use. So now let's work on like your substance use, struggle, and then we'll use that as a way to kind of really, uplift and kind of work and how to like really shift that towards, gaining that level of that balance and that equilibrium that they can actually work and kind of, have some like sense of stability and kind of just a way to really kind of reintegrate back into society. That's the end of our presentation. So we just want to thank you, and then I guess we'll switch up.
So I absolutely fell in love with your recommendations. I think as a budding clinician, I'm always advocating for many of these things that you spoke of. So I see a collaboration in our future, both of you. Conferences are for networking, right? Mm-hmm. So, all right. So now our next portion is about, we're going to cut down instead of 30 minutes question answer, 20-minute question answer. So if you have, like I said before, you have note cards on the table. If you already filled some out, I think somebody will be around to collect them. Give you a couple minutes for that. Nope.
change 12-step process, especially as a practical student. So considering the effectiveness of 12-step membership and having a sponsor, how do I treat patients with addiction who lack interest and engagement in 12-step memberships and turn to their faith communities and family?
You're the first clinician.
Okay, could you just say it one more time, because I didn't get the whole thing?
Sure. So yeah, I just want to start off saying that I'm an individual therapist, so I lack the power to change 12-step process and membership in 12-step processes and membership and having a sponsor. But instead, they turn to their Islamic faith or their family. How do I reconcile the two?
I just want to say that when you're with the client, you're there to support the client on the road. You're not there to cure them. It's a lifelong journey. It needs their faith. It needs their family. Also, 12-step programs are very diverse. You look at the different states, they have different organizations. Even within the state, the different ones will have a different philosophy, and they'll use different language. Some of them are closed, some of them are open. So there's a great deal going on there. What I would do is encourage them on their journey, support them, motivate them to find the natural supports that they can. 12-step is not the only way, It's free. That's one of the reasons it's so popular. And it does provide support because a person who uses alcohol and drugs has to learn how to live without alcohol and drugs. That means new friends, new activities. What do they do with their hands? How do they deal with coping? So as a therapist or counselor, you're only involved in a very little part of their life.
I may also add something about absolutely what Cynthia mentioned, and I would like to add about understanding the 12 steps and understanding the resistance, from where comes the resistance to 12 steps. And by the end, it's one modality which is different modalities available there. But it's very effective modality that we can rely on. And I think back in, like, they used to say, go for 90 groups in 90 days. And there is nothing magic about that other than expose to as many groups as you could to find which group you're gonna fit in. Because also, like, from even personal experience with the 12 steps, I found like there is a lot of diversity in how they take the concept very intense, and some groups would be like sometimes antagonizing certain beliefs or antagonizing certain concepts about the disease. So sometimes help to work with the patient to understand from where it comes the resistance and addressing what the struggle, what they're struggling in 12 steps, which step they struggle with, where they are with the progress in the steps. And again, like if it comes like 12 steps is not for me, there's other different, even free, like Smart Recovery, there's other groups available there in the community. We need like just to connect with them and we know what's the resources available in the community that we connect to the patient with.
And also kind of go off of that with like the Smart Recovery, there's the nice thing about that is they have in-person groups, but they also have an online format to where you can do like, you know, global-wide Smart Recovery groups. You can work with people that are, you know, from your faith or from your culture and kind of incorporating that into your recovery process. But they've also adapted certain 12-step programs that can be more inclined. So if you're not specifically based on like, if you don't believe in like, you know, God as a higher power, you can kind of work in the confines of finding a program that's very specific and tailored to kind of like your specific needs or you know, your cultural identities and kind of being able to work within that frame. Also in terms of like the sponsor, sometimes it helps to kind of shift like the wording. So like instead of saying a sponsor, maybe say like, let's help you find like a mentor. Let's help you find like a guide. And so kind of just shifting that language just a little bit that kind of works within the context of kind of where they come from and just kind of helps to normalize, you know, their experience of like their struggle with addiction as well as incorporating how their cultural values kind of play in there.
So just building off what my colleagues have said, it's kind of also just, building off what people have said is part of the role of being a mental health professional is also being an advocate for your clients. So that may mean going into their religious community or where they're finding the support and providing the information to the person they are seeking it from. So you may not be doing it directly to the client, but you're giving it the information to someone else who's then they're going to be able to hear that information from in a more adaptive way.
What example?
Well, I'm not saying personal information, but kind of giving them what kind of like treatment modalities have shown to work and kind of giving them the psychoeducation they need to kind of provide it, not confidential information yet.
With the whole family, to work with the family.
Right.
Yeah.
All right, great. So this next question is for Dr. Arfkin, and it says, have you seen a decrease of addictions to K2, spice, and bath salts?
So it's interesting, the DEA says the same thing I do, is that K2, spice, bath salts, they're used to avoid being detected if you're on parole, for example, or applying for a job. But otherwise, people are using heroin and cocaine because there's lots of it.
All right. The next one is for Dr. Higazi. It says, is anti-abuse still prescribed to those with alcoholism?
Yeah, it's still available in the market and you can definitely prescribe. It's still available. But I would like to address here, anti-abuse is not anti-craving medication. So the anti-abuse doesn't have to do anything with the pleasure circuit in the brain, and it doesn't antagonize the craving or block the craving. Anti-abuse, we call it adversive treatment, which make like the person sick if they choose to drink. But here, the compulsion is still there, and especially in early recovery, anti-abuse is one of the medications that doesn't help a lot, because basically like still having this strong compulsion, and they end by either like through the anti-abuse and go to drink, or they might drink while they are taking the anti-abuse and they have very bad reactions, so they would learn not to take the anti-abuse anymore. What would help better in the early recovery, it would be medication to block the craving circuits in the brain and to block the receptors. That would found like help more. And even if they drink on top of that, they wouldn't feel any reward from the drinking. So that's like naltrexone or the Vivitrol, the injectable form, that found like to be more helpful in this case. And anti-abuse could be a medication that could be addressed with the patient really like solid in recovery and progress in recovery, and come to me and ask about like, I want to make sure I wouldn't touch alcohol anymore. So evaluating that, and if it's the right medicine for the person, maybe we sometimes use it in these cases.
All right. So this next one is, I guess, for anyone or somebody, I don't know, there's no name. What is the source for the data on 46% of every American college students drink alcohol?
So that was from a national survey done in 2000.
No, go for it. I was going to say, you're the expert on it.
This was a national survey of college students, over 1,000 college students. There was one question about what religious tradition were you raised in. So there were 1,000 people answering this. We don't know if it was a time or because they knew lots of people were answering this question. But when we looked at those who were raised to be Muslim, that's where we got the data.
All right. So this next one, I guess it's another general one. As a school psych, I kind of like this one most. Have you found effective ways to collaborate with schools?
We do prevention programs in schools. So yes, there are ways to collaborate with schools. One of the difficulties is that you have to have positive consent from the parents. It's not that the parents go in and say, I don't want my child to be involved in this prevention program, but we have to say, yes, my child should be in this program and I support them. And that's why the prevention programs often have a family component where the parents come in and see what's being done, and you meet with the parents in the evening.
Can I ask to that? Do you find that within the schools, is it more of a peer-to-peer group, or is it really just professionals coming in and providing information for that prevention?
So, as I said, our prevention program is emphasizing social skills and positive coping with stress. So it also includes some education about drugs. We never say it's targeted because your child is using drugs. This is to help them. And we found the families are supportive once they know the organization, once they know who the provider is. We've had to use a female provider at some of our schools because she's not allowed to go into the boys' classes.
I just have a comment here about the psychoeducation and the presentation about the risk of the overdose death, and that's getting like rising dramatically in the past probably since 2000. There is like big correlation there between that and the notion of like addressing the pain and introducing pain medication through the medical community and working with the pain as a fifth vital. The oxycodone was introduced around that time, so there is a big correlation there with the concept of like addressing the pain and taking that. So a lot of opiate problem now comes to us, and we see that they started usually. This is a normal scenario. Started with the pills, and they get the pills for a chronic pain. The kid has some kind of accident or had back pain from sports injury or whatever. And maybe they wouldn't get it from most probably they wouldn't get from a prescriber, they get it from a friend. and in the end by like hooked it to the opiates and start to seek it from other sources, and then they end by heroin and so on. So that's very important, targeting this population with the psychoeducation. But I try to participate with some of this campaign, and usually like the family has to be involved, especially if they're underage.
So one of the other things, having worked, I currently have a practice on the school side. One of the things we do is, like we said, understanding the purpose behind them. Their use, a lot of times it is because they don't have the coping skills necessary to cope with some of the more adverse events occurring in their life. So we try and do more of a dialectical behavioral approach with DBT, teaching them alternate coping skills to use, which they can replace it with. Because one of the important things is when you're dealing with self-harming behaviors, is not necessarily eliminating the behavior, but giving them something you can use in replacement. So that's something that we have found to be really effective, because now they have something they can use instead of substances.
Great. All right, so this is just a plug. It says lots of addiction treatment info on one of the tables. Is found in English and Arabic, which is the 12-step table. So just an FYI. I think that we only have 5 more minutes, so probably like 1, maybe 2 more questions. So, and I apologize if we don't get to your question. If we don't, we can possibly stalk them sometime throughout the conference. Okay. Sorry. All right. So, next question. Any guidance / thoughts on helping clients whose Suboxone providers are resistant to helping them wean off it once they are stable in sobriety?
Yeah, I can definitely respond to that. So, Suboxone is one of the medication we use it to help with the craving for opiate. And meanwhile, Suboxone is, or buprenorphine, which is the active ingredient, has been introduced as a pain medication. So here is kind of like the dilemma there is like assessing the patient for the need for Suboxone. Are we addressing here the craving for opiates, or there is underlying other chronic pain issues from any other medical comorbidities, and we really like stuck with the pain, and we're working with the Suboxone to address the pain. For some people, they are on Suboxone, they get like to the point that we can't challenge the Suboxone and take it off. And the idea here is like to introduce the Suboxone to support the craving and the urges until the healing happens, or until they are solid in recovery. And here we are addressing all the other psychological approaches and the therapeutic approaches. But by the end of the day, Suboxone is not the absolute treatment for the addiction. It's just the support, the crutches, or the cast that would support the fractured arm until the healing process would happen. And we have to address it upfront to the patient in this way. It's not just like we're going to prescribe the medication and that's all what you're going to do. If you are not participating in the actual treatment, here I don't want to like continue the Suboxone in this way. Other part about the Suboxone, even it has less addiction potential than any other opiates, but it might get to be addictive, and we have to monitor that. So there is some practices that they provide a Suboxone in 5-minute visit every month, which is not supportive to treatment anyway. So if we're gonna maintain it, we're gonna maintain it in the way that really provide it as a component of treatment. And here is the assessment of the all dimensions of addiction: the biological, psychological, mental, environmental, progress in recovery. And we come like we now addressing like a very, we notice a very good progress there, and we can challenge the Suboxone. So here we discuss it with the patient, assuming that there is no other reasons we're using the Suboxone for chronic pain. So here the decision about weaning off the Suboxone, it should be like very critical decision, or very sometimes a complex decision about between the doctor and the patient, and addressing all the aspects of the recovery and where we are in regarding of the progress in recovery. So I hope that will answer, but sometimes it will be challenging, and sometimes we have to take our time with the Suboxone taper. We found it like for people, they are, as long as they are in Suboxone, as it really would be challenging to wean them off the Suboxone. So sometimes we take more time working with that.
I just want to add that, again, recovery is a lifelong journey. And it's not up to the physician or the family to say you have to be off Suboxone. It has to come from their own ability to find support to address whatever reason that they do for addiction. So that's why we don't have these timelines of you have to be off Suboxone in such and such a time. You have to look at what is their support, what is their functioning in life, and then move from there. There are people who are on heroin, people who are on methadone from the 1960s. There are other people who are on it 2 or 3 years and then come off it. We are even starting in Seattle it is a heroin injection site. These are people who have failed Suboxone, they have failed methadone, they keep using heroin. What can we do to reduce the harm to them, to their family, and to society? If we provide heroin that is not contaminated with other things in a safe place, we've shown that it reduces crime and reduces medical problems. And so that's why the United States is joining other countries that offer this as a last resort. Not as a first treatment, but as a last one.
And just to add, it's a harm reduction.
Right.
So it's actually, and it's a way to get the patients from the street more engaging, and probably we move them forward with that, with the treatment.
All right, so we're going to call it there. Let's give one last round of applause for all of us. All right, so we are going to adjourn. The next panel is going to start at 11:15. So see you all. 11:10, just kidding, 11:10.
Which one is in this room?